Let's apply rule number 1 on our clinical studies, which states that equality does not exist. Studies are usually organized to detect which treatment is more effective or safer. Which is the most accurate procedure? Those are the classic superiority studies.
But, what about the so-called equivalence studies? From their name, those studies aim to prove that both treatments are equal.
Equal? How can we look for something that does not exist?
Moreover, what about the literature flooding with the third type of study design known as non-inferiority studies? Concluding that treatment A is not inferior to treatment B.
Doesn't this mean that both treatments are more or less equal? Again violating our number 1 rule.
Let's take an example of one of those studies. People are usually at a considerable risk to develop deep venous thrombosis after replacing their hip. In order to prevent the serious complications, patients are usually given a daily subcutaneous injection of long-acting heparin, known as enoxaparin. Although parenteral therapy is highly effective, an oral alternative would be more attractive, more convenient to patients, compared to a daily once or even twice injections. However, in many conditions like this one where the classic treatment is highly effective, a new treatment will have a slim chance to show a significant superiority. Let's look at the situation in the following way. If the gap between classic treatment and new treatment is small, and judged as being clinically irrelevant, supposing that the classic treatment having a 90-something% efficacy, and the new treatment is less effective by only 1 or 2%. Statistically, if we can prove that this difference will most probably remain within this small range, we can conclude that the new treatment is non-inferior to classic treatment, meaning that it is not significantly inferior both clinically and statistically. The situation becomes more attractive if the small gap can also be filled with the new treatment showing other important advantages beside efficacy, like being given orally, for example, as in our case, having less side effects, being more convenient to certain patient groups, cheaper, or require fewer laboratory follow-up, etc. A gentle reminder that although we have accepted a small negligible inferiority of the new treatment, yet, this new treatment should always be better than placebo. This is the position of the new treatment in relation to the classic treatment. It is slightly less effective, but they are overlapping. A patient receiving either treatment will get more or less the same benefit. But both treatments have to be significantly superior to placebo. And the cutoff point of the superiority is known as the non-inferiority margin. Let's now take a study on the subject published in The Lancet in 2007. The efficacy of the classic enoxaparin in preventing DVT was compared to a more convenient oral anticoagulant, known as dabigatran. The authors have chosen to adopt the non-inferiority design, due to the considerable efficacy of enoxaparin, and the clinically irrelevant inferiority of the oral therapy. Now we should shift to the methodology section to detect the non-inferiority limit of the study. It is the smallest significant benefit expected to be achieved by the classic treatment when compared to placebo. Previous studies have shown a non-inferiority limit of 7.7%. In other words, as long as the difference between the new treatment and classic treatment is smaller than 7.7%, a patient receiving either treatments will not only enjoy comparable benefit, but this benefit will always be significantly better than the placebo. On the other hand, if this difference bypassed the non-inferiority limit, the results of the new treatment will be comparable to that of placebo, and significantly inferior to classic treatment. Moving to the results section, 2 doses of oral therapy were compared to enoxaparin, and in both cases the calculated differences were lower than the 7.7%. Hence, both doses were considered to be non-inferior to the classic treatment. The same logic applies to the so-called equivalent studies. The difference between a non-inferiority and equivalent study is that we are comparing 2 treatments on equal grounds. The small negligible difference that we are trying to put into evidence could be in favor of either treatment, provided that both treatments are better than placebo, of course.
In our workshop, we will cover the 2 study designs in detail. Reserve your place and contact us.